Tanner, can you see my screen?
Yes.
Just be 39-year-old female with moderate to severe cervical pain, 1 week. Also range of motion, pain radiating into the left hand. So what would be immediately your differentials on this case?
First thing, seeing where in the hand it's radiating towards.
Okay.
So I get a little better idea of what level. Good.
Where in the hand is it radiating to, Tanner?
We'll say middle finger.
Good. So what does that tell you?
So that is more C8, correct?
Middle finger?
No, C7. There we go.
So what's your H1?
Here's another question.
Go for it.
Here's another question for you, Tanner. Is it the finger, or is it just the tip? Is it just the finger, or is it the palm as well? Why would that make a difference?
I'm assuming palm as well could lead more towards potentially carpal tunnel, correct? Where there's a little bit more involvement other than cervical.
The other way around.
Ah, okay.
The palmar branch of the median nerve branches off before the carpal tunnel. So if it's just in the fingers, that gives you more of an idea that it could be carpal tunnel.
Okay.
So what's your H1 and H2 on this?
H1, just purely on description, just a segmental facilitation or radiculopathy. But if it's just kind of like a numbness, not necessarily a lancinating pain, I'm going to feel more towards just that segmental facilitation.
Segmental facilitation or radiculopathy causing these symptoms.
Correct.
What in this argues for radiculopathy?
Severe cervical pain and just the acuteness of it.
Yeah, and what would you expect the segmental facilitation to look like?
Weakness through the triceps and flexors.
Yeah, would you expect this much pain?
With a radiculopathy?
No, with the segmental facilitation.
With the segmental facilitation, no, wouldn't expect this much pain.
Cool. What questions could you ask this individual to kind of strengthen your H1 of a cervical radiculopathy?
Pain with certain head movements.
Okay. What would be your expectation there?
More flexion, left side bending, and maybe a little bit of rotation.
And any other questions for a cervical radiculopathy that you would typically ask? It's always tricky when you get to ask this one.
Yeah, the only thing I can think of is it's going based on just fluid flow. Ever symptoms better in the morning or better or worse in the morning or better or worse in the afternoon? Because I would expect with just fluid being pushed out throughout the day,
yeah,
symptoms would be higher at night.
Yeah, and I also may look for looking for a descriptor of the pain. That's where you're kind of looking. If you think it's radiculopathy, are you seeing lancinating? Burning. Does it sound like it's neuropathic pain? In this question. So my question here would probably be to define neuropathic pain in the individual. So you can clearly get them to delineate it. That's you, Eric.
Yeah, I mean that, and you'd have to essentially make sure that the pain is related. The pain in the arm, the radiating pain, is related to the neck pain, right? So I mean, essentially, you'd have to have a situation where the actual pain into the limb is aggravated or relieved by positions of the head or the neck. Without that, you may be looking at two separate problems. That's one of the things Jim really loves to do, is give you guys some random symptom that's not explained by his initial diagnosis.
Mm-hmm. Yeah, that's it. That's really a question I run into. Do I have two things going on, or do I have one?
Yeah. So onset of pain would be another thing. Did they start together? Things like that. Severity of motion loss would be another big thing of the neck.
Yeah.
What percentage wise, are you missing 80% of range of motion in particular directions, like particularly rotation? That could, if you're missing say 40% of rotation to the left side we're dealing with, to the left, what region of the body would you have to examine at that point when you're missing that much range of motion and rotation?
I think that was a question.
Yes, that was a question.
CT junction.
CT junction?
Upper cervical?
Yeah, upper cervical. I think we talked about this briefly when we were doing review last class, when we did some cervical stuff during the review, that the general consensus is that 25 to 30% of all range of motion in rotation is ascribed to the CV region. But most of the studies that do that have suggested that sort of stuff are done on cadavers with rods through the spine, or with the whole thoracic segments removed. There's no blood pressure, there's no muscle tone, any of that sort of stuff that kind of contributes to that. So in vivo, it's actually suggested that up to 70% of cervical rotation is produced by the top two segments, so the OA and the AA joints. So if you're missing more than 30% of that rotational movement, automatic, you have to go in and look at the CV region. Now, maybe based on the referral, that's probably not the pain producer, but it could certainly be a driver.
So Tanner, I think we had the first one. So for objective tests, I think that's where we are now, is what would be the objective tests that we're looking at, to kind of rule this in. And this kind of follows along the process that we talked about, is like, what's your examination sequence? And, this is an examination sequence that's particular to this patient in a cervical region. So from there, we're looking at objective tests, because I already have an H1 that, okay, for Tanner's H1 that we have cervical radiculopathy. We have our questions that we should kind of have positive, and that should strengthen our differential. We believe, okay, this sounds like it's a cervical radiculopathy. And what are the objective tests that we would do next that could further kind of strengthen our hypothesis? So Tanner, what else do you have on the objective tests?
Myotomes and dermatomes.
Any other tests? We'll put neural tension in there, basically dermatomes or neural tension testing.
Yeah, we could do a upper limb tension test.
Put that up in there. And what else do we have? What other tests could be done? Strengthen this if we think this is a radiculopathy.
I'd probably do a Sperling's as well.
Yeah.
Can do a compression distraction. That would all be done in seated position.
Yeah. And, in this case, we're going to go through and assume that all these are positive. Does that kind of make sense? So we're all positive. So all these have kind of strengthened the hypothesis of a cervical radiculopathy. Anything other than objective tests you think of, Eric?
Not that's going to give you a real great, increase in your prognosis, or your probabilities of your prognosis.
Yeah, the other ones would almost be like an ante as you get into them, right? You're using to rule out other things, but when you get into, that's kind of where I kind of broke it down to in the objective tests, like best tests. These are the ones which strengthen or weaken the working hypothesis you have.
Yeah, I mean, I would say if you're showing positive neurological signs, Like I said, there's probably not a lot left that's going to strengthen your diagnosis.
Yeah.
But you do have to do some upper motor neuron tests at that point when you start showing neurological signs. So some sort of, whether it's clonus, whether you go down and do, you know, a Hoffman's or any of those sort of things, even Babinski, et cetera, those sort of tests, make sure that you're not dealing with cord compression versus nerve root. So that's more safety based than it is, you know, strengthening your hypothesis.
It should probably be here. It's more like focus. It's probably be full. So we have the objective test that we use. There's the best test. So like, you know, I think what Eric is, I'd almost put this in as like a upper motor neuron, then it becomes that second tier test where it's, you know, what I put in there is almost that bias correction where here's the information I need to further collect. I've kind of come to my differential to a degree. I'm feeling pretty good about it. But now I need more information, and you also have to do a complete exam because you have to fill out, you know, your evaluation. You have to meet a certain standard and do the additional things. So you need range of motion. You need the other things as well. Okay, they may complement and round out as you search for etiologies and look into the cases, but this would be in that full assessment. So what else would probably be in that full assessment, Tanner?
Would you do lower motor neuron as well?
You've already done that.
Or, okay, yeah, true. Okay.
Full assessment.
Yeah, that's your myotome, dermatome stuff. So you've already done that.
It's okay. What's your eval, Tanner?
Then now I'd go through some more, probably some more thoracic stuff, see if there is a driver in there.
Yeah, because we already have range of motion, strength, dermatome. So we record that. We have Sperling's compression distraction. We have a special test. We have upper motor neuron test. Make sure we don't record compression. Now you're in the thoracic spine looking for, you know, possible contributors, etiologies. Does anyone else have anything now in your full assessment in your eval, the information that you would need for this individual to write your eval note? And this is the information that may not, you know, it could be twofold. It could be looking at, okay, this is my bias correction where I'm going to rule out other competing differentials, and I may do tests to, you know, strengthen my case, or I could be doing it because, hey, I need to write a thorough eval on this individual, so I need more information. Is there more information that you would look for any of these patients? Safety checks is a good thought, but, you know, with no mechanism of injury, I'm usually not real fast to do safety checks on these individuals without a particular reason to do it. As Jim would say in that list of differentials, it may be way down my list. Is that fair, Eric, or would you normally do safety checks on these individuals?
Yeah, I mean, essentially, if you're dealing with neuropathic pain and you have neurologic loss, it's probably not a bad idea to do something involving, at least for documentation's sake, for more medical legal type situations, for the vertebral artery.
Yeah.
The question mark becomes, can you even position them well enough to do that sort of testing, right? Because essentially anything that's going to affect potentially one of the nerve roots, right? So now we're dealing with, it's into the middle finger, we're dealing with C7. You know, the vertebral artery typically enters the spine at what, C6? So we're actually right below where that would be problematic. Or actually, technically, we'd be right where it would, right at it. So that's one of those things that you may think about, but the positioning might be difficult to do. And odds are, if you're having vertebral artery symptoms, if this is potentially vertebral artery symptoms, you'd be having more than just this. So I don't think I'd go running off trying to do a bunch of vertebral artery stuff, just because, number one, I'm not going to be able to get them positioned well enough to do it. And number two, the symptomology just doesn't match up with anything like that. A sharp purser, you know, you could probably no issues as far as positioning that will go with that. But again,
use that if you want to tell the story to somebody else that, yeah, this is an upper cervical issue, that you cleared it, you ruled it out. If I read it in your note, that I know that, okay, this is a non-factor in this individual. It's part of that bias correction.
Yeah. I mean,
agree.
essentially, if somebody has a positive sharp pursor, they're not going to have any range of motion into rotation at all anyway, or cervical flexion, right? Because you're dealing with laxity at that transverse ligament, and everything's just going to kind of fall off the map as soon as you try and rotate the head. So you'd have to essentially have some pretty specific results of your range of motion testing that would make me even consider doing the sharp pursor to begin with. That or some sort of history of trauma.
Yeah, we put it there, your biomechanical exam. Yeah, best I could do a biomechanical and I could look at it. I would try and go in there. It'd be somewhat limited in this individual due to pain and guarding, but then I could just record that this was limited due to pain and guarding. I may be able to move the upper cervical segments, but it'd probably be challenged, but I would try still to kind of take a look at what can I assess, what's limited, Yeah. This individual being age 39, she's going to start to develop some oncovertebral joint arthritis and restriction. So it's possible if I'm thinking, okay, do I get lucky with this person and do I find, an extension subluxation? Compressing the nerve. I think the pain level is a little high for it. I think you're probably going to have an inflamed disc just because of the local neck pain versus a pure nerve compression.
Yeah, it'd have to be a pretty abrupt, pretty traumatic extension subluxation for that sort of thing to happen.
I think so. I think the neck pain with that one
amount of pain
would not make me feel good about that. And if I just have the isolated and the neural pain, without much neck pain, then I'm going to definitely look at the biomechanical. But I hope I'm getting lucky there in the upper thoracic spine.
Yeah. And this kind of goes back to, and we talked about this during the course, as we're going through our process and we're looking at, our scanning exam, which is essentially what, Tanner was running us through right here under objective tests, range of motion, myotome, dermatome, those sort of things. That's our scanning exam, right? So we can come up with basically 3 options that come from the scanning exam. We were relating this to the lumbar spine, of course, but you can relate this. You kind of find analogs with this in the cervical spine as well. Number 1 would be this patient has some sort of medical condition and they don't belong in the clinic. That's the first result. So they're out of the office to begin with. We're not doing any treatment with them. Number 2 is you might actually come up with an obvious disc lesion, right? So something where you say, well, I've done my scan and I already know that the lesion is a disc problem. Is going in and doing a biomechanical exam even necessary at this point during the examination process, during that initial evaluation process? Because is it going to change what I'm going to do as my, quote unquote, first treatment? It kind of depends on the severity of things, really. You may come up with kind of the obvious instability as well, where you're going to have, specific stuff that you have to do without having to go through and do a full biomechanical exam. These are the things that you can find as far as diagnoses go, where your treatment doesn't change based on what you would find in the biomechanical assessment, right? Because with some of these disc issues, you may just be putting them in a collar for a week, trying to get things to calm down. Same with the lumbar spine, where you jump in and you say, you know what, I know this is a disc. It doesn't even matter what level it's at. We're going to get them into an extension protocol as best we can and see where we can go from there. So sometimes that's the case.
Yeah, and again, that was good. The contributions are good. Anything else in this that you would see that we didn't include in the exam that would give us information? Like we know, okay, this is, the age of the patient gives us a certain information about the thing. If it was a lateral stenosis, like that's we're expecting gradual onset, not as much neck pain, on and off intermittent symptoms. It's more gradual push. If we had if it was a bony occlusion or subluxation, the pattern would be different. Okay, we'd have no history of trauma, so we're not thinking, vertebral artery injury necessarily, or something more trauma related, like a ligament tear. So the history then kind of gives us a bit of that. And those are things I may include as I got down to my next section. I may put in there, here's all the things that it's not. If you're looking at all your other differentials, I would tell the story of why it's not likely these other conditions. If we were to wrap back here, maybe one other comment put in here, if we were to wrap it back for clinical practice practice guidelines, this is neck pain with radicular pain. If you want to look at a pathway with that.
I think it would also be important to look at the task-specific goals for her. What's her job requirements? What is she doing? Does she have kids? Does she have to look down a lot? And how do you modify all those positions?
Yeah, as far as treatment, that's excellent. That's patient-centered goal. It's kind of, it's a great thing to talk about is every time you think about this is what is that patient-centered goal, as you plan that next step, because you kind of know what you have with this individual. Okay, they have cervical radiculopathy, they have this thing. The odds are, the stats show they will most likely get better, that most of these are better, within 2 years if you can suck it up and muscle through it without significant neural compromise. So the majority of these patients are not surgical candidates. A few of them will need further intervention, whether it's steroids or injections. But this individual, as acute as they may come when they see him here, understand their prognosis over time, knowing that this is something you may need to be patient with, and it will take a little bit more time to deal with. But the idea of that patient-centered goal in here and understanding what they do, how they sit, how they move, and in there is again, it's an excellent point as you look at this person and plan that next step. Cool. Drew, hate to do it to you, buddy. You out there?
I am here.
Just remember, you're on the interview tomorrow, so if you don't like what we do here, you can always take it back out on me tomorrow, okay? So I have to be kind of nice to you today.
I don't.
Yeah, Eric, on the other hand, is fully relieved of that. All right, pick one. It's 2 through 4. Pick a case 2 through 4.
Let's just do 2 then.
Okay, fair enough. 42-year-old male woke up with a cervical pain, irritation, able to turn his head more than 50% to the left. With that, you could assume that he doesn't have any radicular symptoms since I didn't put it in there. I think from here you start with.
So I would.
Go ahead.
Go ahead.
Go ahead, Drew.
I'm looking at the 50% loss of motion. I'm almost immediately going to look at the craniovertebral.
What's your differentials?
Or I'm sorry, segmental dysfunction.
And what's the second?
With that loss of motion, I would probably want to rule out something worse, like a fracture.
That he woke up
Can you
with.
scroll up? Sorry. Yeah.
Okay.
I say that.
What's more likely to hit somebody suddenly in the middle of the night that could affect the upper cervical region than a fracture? That's still bad news.
Like a vertebral artery issue.
Yeah, come on. What if he had also been dealing with a cough?
Like an infection?
Yeah. Yeah, Gristle syndrome, destabilization of the upper cervical ligaments because of infection. That seems a lot more likely to occur suddenly overnight than fracturing something in his sleep.
Eric, what syndrome is that?
Gristle's, Grisel''S.
Never heard of it.
Oh boy.
Ah.
Interestingly enough, one of the offices, patient Tim would know. I forgot. It's on the tip of my tongue what he had, but he actually fractured 3 of his cervical vertebrae in bed, looking up or extending his neck. But he had a genetic disorder which predisposed him to.
Yeah, it'd have to be pathological.
Yeah, he had a pathological fracture.
Yeah.
That's really rare. I've never heard of it before since. Thank you. That's a Schrott-Marie tooth. But so what would be your likely ones here? So we have fracture infection, but what would be what's the differential that most closely matches segmental dysfunction? That's kind of where you usually are, is teasing out the two that are most like each other. So Drew, you still around?
Sorry. Yep. Yeah, I'm still here. Can you? Where's the?
Yeah, what are the two that are most likely?
The age of it? I would say like in arthritis, arthrosis.
Okay, and that can also occur within, basically a segmental dysfunction or irritation could be in there. But if you want to go acute arthritis.
Yeah.
There, so let's stick with your H1. What would be your subjective questions that would strengthen your H1?
What specific motion increases pain? Is the pain pinpoint?
So his motion is rotation to the left. About 50%, he gets sharp pain. And he's a bit of apprehension when he gets to that point. It's a fair question. What motion?
And
as much as asking the specific location for anything in the subjectives.
And then the other one on there that you mentioned too was the specific location.
Gave that one up.
Hanging fruit.
Again, as you think about that, in the location of the pain, you kind of get a sense of where it's going to be. If it's unilateral, bilateral help, you see it's bilateral pain across the neck, you're probably not thinking, okay, it's not really a classic segmental dysfunction to be bilateral. Not that they can't have bilateral pain, but it's less likely. But unilateral structures generally cause unilateral pain in individuals. Now think about it this way. What questions would you ask to rule out potentially if we think, okay, let's say I would put it as my second, okay, acute arthritis. Are there any questions that would help you rule out acute arthritis? Part of this is when you come with an H2 is, can you test your differential? Is it a differential that's testable?
Yeah, with like an acute arthritis, I would expect more of a mechanism. Was there anything he was doing the day before that could have caused some inflammation overnight?
Yeah. That's a tough one too, because it would rule in both of them. Because you can look at that activity as also causing the segmental dysfunction. So with that question, it helps, but what it also does is you're not able to further differentiate between the two.
Right. I guess with that one, I'd probably get a little bit more specific. And was there, to me, with the segmental dysfunction, if it's like a subluxation, there would be a moment that that caught me, or there was some discomfort, and then I woke up the next morning and it was really painful.
Yeah, I would look for, like, what Jim would term traumatic arthritis. Did something that happened? They get hit on the head. Was there a traumatic thing that hit the joint? If we're looking for arthritis, you can also then go through here in a subjective at this point, if I wanted to, and say, okay, what am I subjective before I go and do my objective? I could then start to think, okay, what questions would rule it out? Okay, well, is there any trauma to this? Another question for segmental dysfunction, have you had this in the past? Like, oh, this happens to me every, 6 months to a year. I get this pain. It's that happened frequently, non-obligate loss of function. He's still able to kind of go to work and get through his day. He worked that day and came into your office. So he didn't lose function. He was able to go to work. He has episodic reoccurrence of this. Those questions are the type that strengthen that segmental dysfunction diagnosis. If I were to get into it otherwise, think, okay, my second in this case would be a disc. The posterior lateral disc, mild posterior lateral disc will look, in most cases, much like this. So I'd be looking at, different things of, okay, what's the severity of pain? Again, how do I differentiate that disc? Is there loss of motion in multiple planes? Do I have any numbness or tingling, radiating symptoms down the arm? Those may be my differentiating questions if I was playing between an H1 of segmental dysfunction and say an H2 of, a disc herniation. Acute arthritis is a good one. It's just a tricky one to differentiate sometimes because they'll come in looking kind of close. And you could have a segmental dysfunction, and a traumatic arthritis or an irritation of the joint from that subluxation.
Dave,
But, working through those two differentials is perfectly fine.
Dave, what are your questions for the disc again?
For disc, it's the same thing. Is there obligate loss of function? Boy, I couldn't look at my computer screen today. I couldn't stay through work. I would look for range of motion loss probably in multiple directions. I look for acuity and severity of pain. I would look for, okay, do I have any radicular component to this? Any pins and needles, any symptoms down into the arm? What other things, Eric, would you look for if you were differentiating this segmental dysfunction from, let's say, like a posterior lateral disc?
Oh, I mean, when you're looking at that sort of stuff, and especially if it occurs real suddenly, the posterolateral disc shouldn't look anything like a segmental dysfunction for the most part. Flexion motion should be worse for the discs. Extension motions should be worse for the segmental dysfunction. You probably have some sort of neurological signs versus, the severity of the pain would be substantially different. Referral would be substantially different. You'd have more with the disc versus less with the segmental dysfunction. It kind of depends on what the segmental dysfunction is, but yeah, I mean, those two things really shouldn't look all that alike.
Yeah. I think sometimes even you get the mild chronic disc irritations, they can be a little more differentiated. The acute disc looks exactly like Eric described it. But some of the chronic discs can be a little slower in presenting. And again, oftentimes they look like segmental. They can almost appear like segmental facilitations when you see them. And then, okay, later on, they evolve into more of a pure radiculopathy. So sometimes you can kind of get a sense of that where you're getting mild neural irritation from a mild posterior lateral disc or an oncovertebral joint. That would do it. Objective tests, Drew. So we have a biomechanical dysfunction. What are the objective tests you'd use for a biomechanical dysfunction?
I'm still going to look at my active, passive, resistive motion. Do a biomechanical exam.
Yeah, generally you're probably going to look at, your PAs and, you're going to look at the biomechanical for that segment. So you think it's a segmental dysfunction. You're going to look at overpressure, your PAVM, your PPIVM there to get a sense of, okay, do I have a restriction at this level? Is it painful, irritated? Jim will usually say, PAs as being his first test. I will do the PA, but generally I'll go in there and do the PPIVM first. But I think, okay, in this individual, do I have a segment? And I will look for segmental mobility. Eric, what's your usually go-to if you're going to kind of try and confirm and rule in segmental dysfunction?
Yeah, I'm going to do my PIVMs first most of the time. In this situation though, I mean, a PA might not be a bad idea just based on the acuity of it. Because again, what's the most likely diagnosis here for me? I mean, we're looking at segmental dysfunction, but I mean, realistically, we're looking at Rhineck, right? We're looking at an acute torticollis. So it's probably a subluxed facet. It's probably what the issue is. So doing PAs would give you at least a level that the problem is at. You may not need to worry about PPIVMs because the treatment's going to be gapping anyway. I just need to know where it is.
I'll put range of motion in that first one.
Yeah.
That'll kind of give me the information that I need. Okay, so you get those, and Drew, just like the other one, these confirm what our differential is. Now, if you do our full assessment, what does the full assessment then look like? We have our PPIVM, our PA, we have range of motion. What do we do? What do we do next to kind of complete out our eval? And it basically also part of bias correction to say, hey, we're gonna look at other things to make sure that we just don't kind of close this case up, and then we're gonna look for these other differentials. What does your full exam look like to get the information you need to kind of complete your eval?
I would probably go through a neuro screen.
Okay. And by that you mean?
I would start with myotomes.
Okay. I assume you also mean dermatome and?
Yes. And upper motor neuron.
Do that.
Because of, with the loss of motion, I probably on this patient would do some safety testing that we talked about in the previous one.
Yeah, safety testing is good, good for two things. One, then you kind of know, okay, there's no risk here. And two, you're probably going to manipulate this person. So having documented safety testing here is an important point. The point that, okay, you gave this a consideration before you went in and manipulated the cervical spine. So safety testing is a good one to have in the documentation, to have it in there as well. What other things as well would you look for?
After that, I would probably start looking more towards drivers, down the spine, CT junction, maybe in the thoracic.
Probably one other thing that you need to think about from a bias correction standpoint still. So what is our
diagnoses?
Yeah. So if we're looking at our typical biomechanical examination, we have, just in general, whether lumbar spine, thoracic, or cervical spine, we have passive mobility testing, combined movement testing, which, will fall into our range of motion testing. And what's the third thing?
You said strength testing?
Strength testing? Well, that's what we're doing with our neuro screen. Dave almost jumped the gun there.
I was putting up little cues.
Still jumping the gun. There you go.
Give it a little hint.
Krista's helping you out.
Okay. Yeah, I don't know. I guess I can include that with the safety testing for ligament stability.
Okay. Well, that's just one thing that we need to mention, right? Because you may be thinking it in your head, but we want to make sure everybody's hearing it.
Gotcha.
Because you got to make the assumption that, well, yes, this person comes into the clinic, they're probably sitting like this, they can't turn their head, and there's all that sort of thing. It's very acute, looks just like that very typical wry neck where you have a subluxed facet, but you could have a very irritable instability as well, right? So you need to at least be able to produce some sort of stability testing here, at least for documentation's perspective, to say, yeah, I went through and looked for that potentially. Because when you're looking at your treatment technique, you're going to probably end up manipulating this person. And, you need to be able to defend the idea that, I did everything I need to do to make sure that this is what I'm dealing with. So the PPIVMs, in most cases with wry neck, they're going to give you spasm anyway, right? So you're going to have a real tough time getting to, that pathomechanical end feel. But this is one of those rare cases where we're going to manipulate through some different, most of the time through some sort of different end feel. But we have to give the patient a certain amount of choice here with it as well. And I can go through how that process works here when we get through all this stuff if you guys want. But the idea that you could have just an instability, some lower cervical instability thing that got real dinged up, because that'll happen in your sleep sometimes. That's the problem with instabilities, is those things can be real unpredictable. So that's just one other thing that we have to make sure we're doing, is that we're actually going through and doing these linear shear stress tests, anterior, posterior, lateral, and even potentially rotational, although we're not going to produce a rotational force with our manipulation, so we don't necessarily have to get too worked up about that one.
Yeah, but it's that understanding the motion state of the joint. I agree. It belongs in here, and it should be in here. When you get to this one segment of interest, you're right. These will probably be limited by spasm.
Yeah.
But it's part of the thought process where you'll be able to look above and below.
Yeah, you may be able to get past the spasm if you move with the PIVMs and those glides real cautiously, real gingerly, in order to find your but more often than not, when you're going in and you're doing your PIVMs, you're just going to go and you're just going to run into that thing, just that muscle just firing right away. And basically all that's telling you is this is the level that's the problem. So once you go through your bias correction, you can pretty safely assume that that's the issue based on the rest of the presentation of this patient. What else? Do we have anything else we need to do here?
I think on there, that's pretty good. Anything else missing from there?
At the seat.
Yeah, I feel like there's an extra vowel there. So if you're looking at CPG on this one, you know, you're probably talking there, they'll talk about this being a mobility deficit. So again, though we don't preach or really talk too much about clinical practice guidelines, you see there, you can subcategorize all these patients into one of them. But it doesn't, but the diagnosis isn't there a mobility deficit. You know, what we need to do is then figure out these things, have a bias correction to make sure that, okay, we have a process to determine, we believe it's a segmental dysfunction. Okay, we have the information to support the segmental dysfunction, and we've done the exam to further exclude other competing diagnoses or strengthen this. Or the third one is to find, you know, other contributing etiologies that are occurring within there. So if this is a mobility deficit impairment case, all these other things have to happen. Knowing it's a mobility deficit impairment doesn't help me any further along in the evaluation of this individual, but it's nice to be able to relate back what's being published to the process that we're using and what you're doing in here. But you see how this process kind of flows as we look at it. Tanner Timmerman, if you're out there, do you want to take the 28-year-old female quickly with a headache?
Yeah, I can give it a shot.
We'll pull through a little bit to try and cover it. Now, there's two of them in here, and let's play with both of these. The first is a 20-year-old female with headaches, noted on and off over the years since an MVA 4 years ago. Let's play this one off of the 28-year-old female, status post MVA 6 weeks, with a right-sided headache, increases sitting at work, driving, episodes of dizziness at first noted, and this resolved after 2 weeks. So both females have headaches, but different presentations, correct?
Yeah.
So let's look at number one with the one who's had 4 year status post. What's your H1 for her?
Um,
4 years later.
probably more. I probably more towards like a cervicogenic headache.
Mhm. Okay, gotta have an H2. And this doesn't have to be, just think of what would be the next most likely thing that you want to play the two off of each other.
Yeah, I got to review my headache stuff a little bit more, I think.
No, it's okay. I mean, it could be, you could go down to, okay, like a segmental dysfunction could be one in there. It could be disc herniation, could be fracture infection.
Yeah. It'd probably be like a segmental dysfunction.
Okay. And again, that segmental dysfunction could also be, like we have a servogenic headache, it's kind of the diagnosis. At this point, I almost put the segmental dysfunction in here as kind of one of those contributing etiologies. So you put segmental dysfunction, but chances are what we're going to have is probably, what are the chances of a servogenic headache being caused by a segmental dysfunction? We're hoping it is, aren't we?
Yeah.
Do something about that.
Mm-hmm. So what are the scenarios here for thinking, okay, let's think about servogenic headache when she's a chronic segmental dysfunction. What do you think the motion state of this joint likely is if she's having headaches on and off 4 years later?
She's probably got a hypermobility or an instability.
Yeah, that would be my first thought. Eric? Any first thoughts on that one?
Yes, with a caveat.
Mm-hmm.
I will say yes with a caveat. I'll save my caveat for in a minute.
Okay, perfect. So again, if you had to think of a question to kind of strengthen this diagnosis, you know, what would be a question thinking about, okay, what's your pain generator to strengthen your thought process that this is a cervicogenic headache that's potentially caused by segmental dysfunction?
So I'd be looking at like different postures, increase or like trigger headaches, like whether it be like sitting at a computer or like looking up or different things that are putting stress through like the upper cervical spine, then I would assume that they would have reproduction symptoms with that.
Mm-hmm.
And alleviation with more like non-weight bearing, like laying down probably, is you're not getting as much pressure through the upper cervical spine there.
Okay. Any questions you put in there, Eric?
Well, I mean, you'd have to expect that it would be reproduced by movements of the head and neck.
Mm-hmm.
Your movements or positions of the head and neck.
Yeah. So it'd be under number 1 of even that question of provocative symptoms. We can put in there.
I probably want to know like intensity and description of pain as well. And I don't know, did it say like where the symptoms were located? Was it right-sided headache?
Up there, I think I put it on the side. I don't think I put it on this one, but we're gonna put it on the right side, like the next case. And this individual too.
I guess I'd want to know like where the pain was located at, because then you'd rule out possible like muscular versus like joint. I mean, it's all gonna be driven by the same thing, but you're trying to be specific and figuring out what's the referral pattern there.
Yeah, let's say it's in the upper third of the cervical spine on the right hand side. Is that a good region to generate a servogenic headache?
Yeah.
Where do most servogenic headaches derive from? Which region?
C1, C2.
Yeah, I put C2, C3 in there.
You could just say CV region. It's
Yeah.
top 3 segments.
Mm-hmm.
Hey, CV region. Let's do that.
Yeah, that's really going to be where your most of your pain your generators are. Not that you can't have pain in the lower neck and lower neck dysfunction and then offsetting upper craniovertebral joints, is having a lower cervical as a driver, which could be a possible driver in a case like this with a servogenic headache. That you have a lower driver affecting the position of the craniovertebral joints. Cool. Tests. That's where I would be next. I want to look for those questions which differentiate it, kind of help strengthen my differentialness. And then, okay, what 2 tests would be the test to look for to kind of strengthen the differential?
I'd want to look at like range of motion, and then probably just like a biomechanical exam looking for either like a hypermobility instability or a hypomobility.
Yep. Eric, anything to add on that one?
No, I mean, from a bias correction, yeah, but not from
Not from a differential. It'll be the same
objective.
thing.
Yeah.
Yeah, that should be give my information. Then from there, then you definitely need the bias correction, and that comes in if you think about that full assessment. Like from there, we have our questions which were specific for it. Okay, I went in and we looked for, okay, what's going on with this segment? What do I feel? And then now I'm into my full exam, and that's where we want to get into. Okay, what are we looking for as far as bias correction and differential? What do you think would be good differentials here? What other tests would you want to do to this individual? Again, you have to fill out your paperwork at work. So what's your complete exam look like?
I do a neuro exam, and then
Here's a question. What does your neuro exam look like for this patient? Is it going to be different?
Yeah.
Where are their symptoms?
Upper cervical.
And in the head.
Yeah.
Yeah. I think Krista's got you there on the chat.
Oh, yeah. I'd probably do a cranial nerve exam. Thanks, Krista.
Yeah. Yeah. Versus doing extremity, myotome, dermatome stuff. you're probably gonna look at doing cranial nerve stuff instead.
I'd look at like some upper motor neuron tests as well.
Yeah, that's what you want to round out the exam on this individual. Because here you're looking at, okay, you want to prove, okay, we don't have a, so we think it's really what we're looking at as a servogenic headache caused by a segmental dysfunction. And the dysfunction here, we're assuming is going to be a hypermobility of somewhere up in the CV region. So we're ruling out, okay, it's not a disc. We're not looking at lateral stenosis of any type. It doesn't really fit the description of what you'd see in a lateral stenosis. But what else we want to do with this individual? Okay, we have now old MVA. We have this. We have a cranial nerve exam. What else do we want to do as far as testing? And feel free to look back at the previous case.
Yeah, I'd probably do some like safety screening.
Mm-hmm.
You look at probably a little bit of the ligament testing as well.
Yeah. What ligament may also be a contributor to a unilateral headache if it was disrupted on the right side? Which ligament test might be positive? Bonus points. Actually, not really. Damn it, Jenna. So don't read the chat.
I already read the chat. It'd be alar ligament probably.
Yeah, no, it's tough to be on the spot. So you can ask a friend and do it all the time. Yeah, alar ligament. Jim wrote a little bit at one point. That can be cause of chronic headaches and irritation in individuals. They have alar ligamentous laxity on the side. They tend to get these headaches. I don't know if you have any more information on that, Eric, but I know Jim had written about that and talked about that in prior stuff.
Yeah. I mean, essentially, as far as pain goes, you're almost better off tearing the damn thing rather than having it be elongated, because you're just going to keep pounding away at it. And it's not even necessarily just the alar, because essentially once it's a little lax, you're going to start putting more pressure on the articular structures as well, because you got to find that stability somewhere. So usually that's via friction, compression, all that sort of stuff of the actual articular surfaces.
We're back in there now, passive mobility and stability testing. There's an hour. Well done. So the idea behind this exercise was to see, we said, okay, well, gee, what does the exam look like in like a routine? You see there's a model to it. And it's kind of the thought process of taking that history, developing an H1 or an H2, testing out for that, and then having that focused exam where I go right into my best objective tests for that individual, my best objective questions, and then my full examination and other things and questions then become part of the bias correction. Now, as I say, if I'm in subjective, I'm sitting there, I may ask them the 2 questions to strengthen my differential. And I may ask them the questions related to my bias correction for other conditions. So I may put my questions up in there, but I'm basically checking boxes down in my full assessment when I'm asking those other questions. I'm not asking those other questions and muddying up my thought process. I'm looking at bias correction at that point. And same in my objective test. As I go through this, I'm doing my full assessment. I'm collecting information to develop my differentials, etiologies, and then I got it, Eric. Thanks. And then, and then going into my exam to complete out my exam to make sure I have full information, and I can, then provide a good treatment plan. But I'm also not skipping over steps in these individuals. This is kind of how the cervical exam will flow. So I thought this was a good one to do today, because this is what we'll kind of practice and go into as we go to the cervical module. We'll spend some time on the Friday or Saturday morning, kind of going, just renewing this process and going over it, making sure this is kind of part of what we do as we look at the cervical spine. So you feel more comfortable with the flow. And again, I remember 2 weeks ago, this came up and it's something I wanted to do. If we look at this, this is a basic clinical practice guideline. Neck pain with servogenic headache is the clinical practice guideline that this would fall under. But as you can see, there's more to it than just kind of putting it into a pattern. is just saying, okay, it's a neck pain with servogenic headache. We need to determine, okay, what's the articular dysfunction? Is it hypermobile? Is it hypomobile? You know, what is the articular state of it? What's irritated? Do I have an alar ligament tear? You know, do I have a subluxation at C6, C7, and, you know, into flexion causing an extension subluxation at 2-3, giving me the headache? So it is a little bit more complicated than just taking the CPG and applying the stuff to it. It's good because it frames out what we will end up doing, but we're going to be we're a lot more specific in this training method. It's kind of where, you know, everyone gets a fellowship education when they do this. It's kind of that differentiation of, okay, what maybe residency or entry level, and what is kind of the curriculum we're going through in fellowship level, and how you can still the CPGs, but we go way beyond it. And Jim talked about that early on in this. So it's just nice to kind of come back to it so you can relate what's being published even to what we're doing here. And I know I always promise this, but Deb always makes me be honest and post what I say I did. I will save this, and before I get out of my chair, I will send it out on the discussion board for those who'd like to see this. And any